continue, please.
If I can close this part of it and get to your questions. Again, our approach, in our view, the cost of healthcare is not the issue. We all are sort of now programmed to say, we've got to bend the cost curve, et cetera. If everyone is receiving the exact amount of health care that they need, whether it's on the first day of life or the last, that's what we want. That is the goal. We want people to get health care. The problem isn't the cost of health care. The problem is the excess cost of health care. And excess cost is driven by overutilization and underutilization. We don't talk about it this way. But every time a child with asthma ends up in the emergency room, that's actually a failure. That's underutilization that triggered a higher cost because it was totally preventable. Every time a senior citizen who's on too many medications slips, falls, breaks a hip, and enters into the healthcare system that way, that is overutilization. That also was preventable and avoidable. And the idea that now, as we are entering this new phase, to where healthcare cost is approaching, we're going to spend $1 out of $5 on healthcare. I don't think there's anybody who really believes that's sustainable in the long run. A family cannot afford to spend $1 out of $5 on their healthcare. They've got other priorities. A state cannot afford to spend $1 out of $5 on healthcare. There are other priorities. But the key, though, is the utilization. To change someone's behavior, whether that is the individual member, whether that is giving the incentive to someone else. Personally, I've had a thing that I think pharmacists actually can be more engaged in helping to coordinate the care of people in the healthcare system. No more trusted healthcare advisor than your pharmacist. Seniors in particular see their pharmacist quite frequently. One of the markers of what we call a super utilizer is how many prescriptions are you on. Again, a lot of this is not mysterious. If you're on 4 or more medications, we know you have chronic healthcare conditions that are going to be extremely costly to you as well, because someone with chronic healthcare conditions, arthritis, you're going to miss work, you're going to miss activities of daily life, things that you are not going to do because your health, your diabetes is not under control, your hypertension is not under control. So this is again where, who do we give the incentive to change and to get the proper utilization of care?
Before we go to questions, I did want to give our broader team a chance to very briefly introduce themselves. And I wanted to use that as a way to further exemplify this idea of the big engine behind the thought leadership, because they're doing a variety of projects, and I want to let them speak to that. So we're going to start with Leslie, and I asked them to use their outside voices because they don't have microphones.
Good morning, everyone. My name is Leslie Chambers, and I'm with PCG. And one recent project that I wanted to highlight is...
I'll tell you, we got folks who aren't going to be able to hear. I think if you
Let's just have rotate into the microphone seats, and then we'll just rotate around. So why don't we rotate 3 in, and then when the 3 have each gone, then we'll rotate the other 2 in.
Okay, is that better? Okay, thank you. As I said, my name is Leslie Tremberth, and I'm with PCG. And one recent project that I've been engaged on is with the state of Virginia. They're in the process right now of doing a comprehensive assessment of their behavioral health system, looking for opportunities to increase cost efficiencies while improving the quality of care. And so they've asked us to take a look from the gamut of the inpatient psychiatric facilities down to community-based care. They currently have a very high utilization of the inpatient psychiatric hospitals or institutional care. And so they're really looking for ways to move people into different levels of care if that's appropriate and realize the cost savings to the state along with that. So that's one place where I've worked recently.
Morning, my name is Jonathan.
Morning, my name is Jonathan Wilk. I'm a native Arkansan and a PCG employee.
the most recent project that I've worked with, and worked with actually since the very beginning, is the current AHIM, Arkansas Health Insurance Marketplace project here in Little Rock. And my main focus is the regulatory analysis and looking at the various regulations and laws that are associated with starting up a health insurance marketplace in Arkansas, and how that affects, and then the things that need to be done and can be done through the regulatory tools.
Hi, my name is Ashley Odom. I wanted to highlight a project I'm working on with the State of New York Department of Health through their Medicaid redesign waiver. It's the DSRIP program, the Delivery System Reform Incentive Payment Program. And PCG is the independent assessor, so we evaluate the performance of the program, evaluate that the participating providers and hospitals are achieving performance and quality improvement targets in order to receive funding, and it's at least a $70 billion investment by the state. I have also previously worked in North Carolina fraud, waste, and abuse, identifying overpayments in Medicaid claims, doing data analytics, and also desk audits, and then also provider screenings to kind of look at where there is excess utilization or excess payments, fraud, waste, and abuse. And I also am a native Arkansan from Mountain Home, Arkansas.
Good morning, everyone. Thank you for your time. My name is Rachel Ratchford, and I also work at PCG. I just want to highlight an experience I've had with the state of Delaware. For the past few months, we've been working through their Qualified Health Plan, QHP, certification process and review. Our overarching goal with that work is to ensure that consumers have choice as they look for plans that are appropriate for them and their families, both on and off the exchange. So with the Department of Insurance, we've been working to streamline the processes and plan a sustainable framework that will allow this process to continue in the future. We also are doing the legwork behind the QHP certification as well. Thank you.
And good morning, everyone. My name is Pete Haney. I am also from PCG, and I would just like to highlight our work with the provider community. I'm currently helping the Massachusetts Health Policy Commission conduct a study of their community hospitals across the state. Many of these hospitals tend to be smaller, independent hospitals located in some of the more rural areas of the state. So we're talking with these hospitals and these providers about their plans around payment reform, delivery system reform, and ultimately determining how the state can step in to provide the necessary technical assistance and investments to keep these smaller hospitals thriving and ultimately keeping care local in the community. This project requires a lot of stakeholder engagement work, as well as health policy analysis and recommendations, and I know that we look forward to bringing that experience to you here in Arkansas.
One thing I wanted to add, I have to brag a little bit more about Jonathan than he gave himself credit for. So Jonathan is a member of the Arkansas National Guard, and he has spent the last 5 months in training, and he was on his way back from that yesterday driving through Texas, and I called him up and I said, Jonathan, can you have a suit on at 9 a.m. tomorrow morning and be here? And he said, yes, sir. So he's a great addition to our team and reflective of our intent to hire more folks in Arkansas and have this be part of our community. Okay, I think we're ready for the questions.
Okay. We've got 4 standing ones, and I think we'll start with the House side. You've got some folks there that have some.
Yes, Representative Hammer, you're recognized to ask the first question. If you push your button so we can turn you on.
Thank you, Mr. Chair. Thank you all for being here to present this morning, and especially thank you for your service to our country and for your willingness to be here on such short notice. Could you, for the benefit of the community, describe what makes your firm unique in the industry? As you know, we're hearing requests for proposals from several companies So what is it that you'd want to tell us that makes you think you're better than the other ones to kind of leave that impression, please, other than what you already said this morning?
Thank you. I'll kick us off with that. I think you heard Dennis speak to the connection between health and human service programs, that these programs aren't isolated, and that there are opportunities to change things you're doing in the food stamp program that can directly impact the goals you're trying to accomplish with healthcare. One of the things about PCG is that we are the big engine, not just for health, but our firm is dedicated to public sector in health, human services, and education. So we actually have units of our firm who focus on implementing work requirements related to the food stamp program, all those sorts of things. I think we are more capable of connecting the dots across those programs. I definitely think that distinguishes us. The other thing that I'll mention is we're the first firm who has written a state-specific paper on 1332 waivers, not a theoretical paper about what's in the section of the law or anything like that, but a specific state analysis, and that state happened to be for Arkansas. We had the opportunity to do that at the request of the Marketplace Board, that is also looking to try to be innovative in the way they implement their programs. They're not looking to be a marketplace like any other marketplace in the country. They want to do it the Arkansas way and with specific goals. So we have laid out in that paper very specific ideas about how this new waiver authority, which really is the closest thing to a block grant that you're going to find, how that can be used in Arkansas to try to meet some of your goals. Cindy, Dennis?
Good morning again. McKenna is a nationally recognized law firm with offices in Atlanta, Denver, DC, New York, California, and Korea right now. And we have chambers, 500, we have recognized lawyers in the health space that are phenomenal, and in health insurance and healthcare regulatory law. But what makes us unique, we believe, is that McKenna has allowed us to create within the firm this little health policy group that focuses, that is made up of people who really believe in public service, who've been in and out of government, and we've tried to focus on being part of the national dialogue and national debate on where health issues are going. We work with think tanks that are out there developing ideas. We work with congressional staff. We try to bring to the forefront through writing and speaking, dialogue and other activities, the ideas that are developing out there and challenge sort of the status quo of this is the way things get done. The last 5 years of the implementation of ACT have been a period where our lawyers back us up. We turn to them constantly to help us take ideas and try to make them real, and they provide the legal. We'll do team with other groups like we've tried to do with PCG here, who have the on-the-ground expertise and the technical, is called the big behind, to take ideas and make them real. But we really do try to position ourselves and stay where we don't get mired down in this is the way things are done, but instead really trying to look at the system holistically and figure out how could it be done, who's got good ideas, how could you take those and advance them. So right now we're having a lot of, we're doing a lot on 1332 waiver concepts, how those could work. We are even doing a good bit right now around King v. Burwell, right? If how King were to win, what would be ways to handle that, what are solutions? So that's what I think makes us unique, is I don't know of others that have allowed that kind of a health policy unit to be developed within a firm.
If I just may quickly add, I think one of the other things that is a unique opportunity in Arkansas and the benefit, the extra value that McKenna can bring, which is a recent Supreme Court case in Idaho that the state won, and knowing that Arkansas has been under a number of very expensive consent decrees by federal judges, that again, I think that court case opens up the opportunity for dealing with some of those cases. The last thing that I would add is, while I think you will find a number of whatever firm you bring in, there will be commonalities. There are certain things in, like Medi that are sort of stock and everybody can pull it off the shelf. But in our experience, every state is unique. Every state has its own markets. Every state has its own mix of payers. Every state has its mix of what will work. You cannot impose something from outside if it is not already organic in the state. You cannot move a certain type of intervention in an area that if it's not supported in the commercial market, it won't work in the Medicaid market. Again, as I said, Medicaid is part of a greater system, and those things, it has to work. You can't just impose it from the front. So in all the states that we've worked at, been very uniquely tailored towards what works in those states, the opportunities in those states, the partners that you have in the states. Medicaid fundamentally is a purchaser. We finance healthcare. We don't deliver healthcare. The doctors and the dentists and the pharmacists are the partners who deliver healthcare. And what you do is look for your willing partners and help them work together with them. That's what I said in my opening remarks. Stock trade off the top, cutting provider rates. It doesn't work in the long run. Your providers are the ones that are your partners, and you want to build stronger relationships, not weaken the overall system.
Before I move to the second question, I'm just going to channel a question from my co-chair, which is, could the three of you that are at the table describe for us a little bit how much, kind of TLC we're going to get from the three of you, and then give us a little insight from the other five individuals, and then I know the big engine has more than that, but give us a little bit of a sense for that, please.
Well, I can start. Some of you may already see me around town quite a bit. I'm definitely here a lot and intend to continue to be here, and this is my focus. And I've gotten a chance to build some relationships with some of the other agencies through other work we're doing, and see a lot of opportunity to connect dots and all of these things we're trying to do.
I think the first step for me, I've done a lot of talking this morning. My first step would start to be listening and what your concerns are. You all, I'm not from Arkansas. You all have your own particular interests and constituents, and to be able to spend the time with you to understand your own experiences and priorities, the needs of your communities. Healthcare is personal and local. And even in Arkansas, you have different markets. And we, again, my perspective and approach would be to listen to your interests, concerns, and help
Let me just try to tweak my question a little bit. So Rich, basically, this is a high priority of his work week is Arkansas. And for you, sir, is it, is this one of 300 things you're working on?
No, sir. Not one of 300. This would be at the top of the priority list.
Okay, wonderful. Ma'am?
Exactly the same as Dennis. This would be at the top of our priority list. You'll see as much of us as you want to see, and probably more. I actually live in South Carolina, and so the way my business works is every week I get up on a plane and get on a plane and go somewhere, wherever my clients are. So, would love to be able to not have to fly all the way from South Carolina to Denver. It'd be wonderful to be able to be here. So, we have all had experience working in states and working with state health reform. And just as Dennis said, we all know it isn't something you do from a distance. It's something you have to do live in the state. And the other thing I will tell you about Dennis and myself and our team, this is the team. Yes, we have lawyers that we will turn legal questions over to, but this is the team that you're getting. It's Dennis and me.
Okay, wonderful. And I know the other five, when they introduced the projects they were working on, you could see the expertise here from rural hospitals to regulatory issues, et cetera. So I think we got a good feel for that one. So now what I'd like to do is turn to Representative Boyd. You're recognized for question number 2.
Thank you. Thank you for being here today. Please describe the biggest driver or drivers in escalating healthcare costs and specific measures that have been demonstrably successful in changing the cost curve.
Well, the costs are really 2 different parts. First, enrollment, and second, the per capita cost of each of the individual eligibility groups. As I said, the first part, eligibility enrollment is still exceeding historical levels, and would be something that I think you need to deal with. Secondly, again, making Medicaid, making people who receive Medicaid, the able-bodied working population again, not people with disabilities, but to understand that Medicaid is temporary, and to engage them in many respects that helps to prepare them to go back to work full-time. One of the, and I've found that to be quite successful, in engaging individuals, raising their expectations. One of the things that I've done, and even in programs for serving people with disabilities, to say the old way is focusing on what you can't do. We're going to turn that around and focus on what you can do, and we're going to build a plan of care around you that supports what you want to do and the system around you, including your family care, the care of your family members. Often what happens to an individual is because something else has happened to another family member. You're a young person with a developmental disability, and your young older brother or sister goes off to college. That affects your life. Now I've lost an important relationship. How do I come back with that? A plan of, and when we're talking about the per capita costs, it's not in the moms and kids population. It's in people with disabilities, and they're going to be on Medicaid most likely for their lifetime. Again, changing expectations, supporting family members at home. We had very high out-of-home placements for people with disabilities. So going back in and saying, going to a group home for a young person with a developmental disability, $100,000, $125,000 just on room and board, and that doesn't include their actual medical care or the treatment services. So again, to reverse that, what will it take to support this family? It's a tragedy. I don't know if you've heard it before, but having a child with a disability is that there are extremely high divorce rates among families with a child with a disability. So again, I don't look at it as just a healthcare issue. I look at it as a family issue. What does this family need to stay together to keep Dennis at home, to keep Dennis as part of the family as long as we can? And by the way, then that saves the taxpayer dollars. So those are a couple of examples.
I'll just add to that real briefly that the track record of Dennis and I worked together in Wisconsin. We closed a $450 million state budget deficit through the Medicaid initiatives. Much of that effort was about maximizing private insurance for able-bodied individuals where that made sense, and then delivery system reforms for longer-term care populations. One of the things we did was a health home for children in foster care, moving out of foster care, who connected them to Children's Hospital and provided unique services that, as Dennis has said, meets their specific needs at the right level of care.
Okay, I'd just like you to clarify one thing you said there, is as we talked about this bid in the cost curve, because you said it both in the presentation and here today, is, and I think it's important. You mentioned that you believe that continuing to try to do reforms by cutting reimbursements to providers for the cost we're paying with our partners who are providing the health care is not the appropriate way to go, but yet you can still drive the cost down. And I guess that you're saying that because of structural change and eligibility, and what other types of structural change would allow you to do both? Take care of the providers, but also drive the cost down.
Again, it's engaging both the individual and the provider community in the coordination of that care till you get the correct utilization. So I believe there is a role to, again, engaging a member that they will actually keep their medical appointments, to keep their dental appointments. And there's mixed literature on the success of providing incentives on the wellness side. But I think from experience that I've seen, to have a engaged care coordinator in that individual's life, again, I'm talking about the high-cost people, which is a subset. They're the drivers of healthcare costs, and they're the ones supported. For most of the folks, as I said, the moms and kids, non-disabled, non-working population, the expectation should be you're going to have personal responsibility in that you're going to help contribute to the cost of the care, and we are going to create an expectation that your stay on Medicaid is going to be short as possible. But on the per capita side, it's the high-cost utilizers who are making those multiple trips to the emergency room, who are seeing multiple physicians and prescribers, and who are not having their care coordinated because they're sort of wandering around out there in the wilderness on their own. They're the ones who will benefit the most from well-coordinated care, and that saves dollars.
Okay, thank you. For our next question, we're going to the Vice Chair of Audit, very bashful Senator Chesterfield.
Thank you so much, Mr. Chair. Thank you for that wonderful introduction, which described what constitutes a thorough audit of Arkansas's Medicaid program and the expected results of such an audit.
Thank you. We're very committed to this part of the scope of work. This is why we didn't come in as the lowest bid. We believe there is a level of effort which is not going to be about what you pay, but what the return on your investment is. And I hope I've already made that impression by talking about some specific ways that you can get a return on your investment. Dennis said the words, the hard slog at the beginning. This is where you get into the engine. This is about the claims pieces. This is about the eligibility edits and audits. This is about providers as well. And when you hear providers, people think hospitals, that sort of thing, but there are many very small providers in the Medicaid program. When you get down to personal care levels, those sorts of things. And you have to have a good system for making sure that there's program integrity at those levels as well.
Will you be doing an audit of each one of those programs individually, or will you be doing an audit predicated on percentages? How will the audit work?
It will be a comprehensive audit focused on those areas, eligibility, claims, on assuring provider integrity, and the effort is to identify any place in the system where things are broken, and to identify those so that we can have action items coming out of it, and not just some theory, but some very specific action items that have price tags on them of savings.
We're not talking about generally approved audit. Are you describe, because I'm not getting what you're saying. Are you saying that each and every person who is currently on Medicare or Medicaid, you're going to go in individually and look at each and every one of them to determine whether or not they're eligible or ineligible? And then you're going to go to every provider, whether it be hospital or mom and pop shop, And you're gonna audit each and every one of them to see if they are doing as they're supposed to be doing by the audit you provide.
It's a program-wide focus. It's a program-wide focus because what you have to do at a high level is identify where, what we call the Medicaid enterprise, the whole engine, where it's broken.
So you're gonna go in and do everybody, is that, I just need an answer.
What I mean by program-wide is that it's not every single person, it's the administration of it, it's the edits and audits of eligibility. So you're not going one person by one person, you're looking at the way the system is administered for all those people.
Okay. I guess I'm looking for a little bit more specificity, other than you just saying we'll look at the program. Which program? Who is providing the program, the recipients of the program? How will you address that as we consider giving you $2 million?
Senator, if I may step back a little bit and to audit the systems and the programs themselves, which on a claims basis, for example, we may take a sample of the providers to see if claims are being paid correctly. Are they being paid promptly? Are they being paid the right amount? But that would be a sample, it would not be each and every individual
That's what I
provider.
wanted to know. So you will not be doing each and every one?
No.
You will be sampling?
No, sir.
And then you will be making decisions based on the sample of the program or provider?
Correct, sir. It would be a sample, and again, it would be a recommendation to say, we would look for, as another example, on there are many different types of providers. Looking at the drug rebate program, for example. Is the Medicaid agency collecting rebates quickly? Do they have, and there are some manufacturers who sort of let the clock run as long as possible. So is the agency sending those demand letters out? Are they sending them out on time? If you are a dispute, are you going into an alternative dispute resolution to solve it? Or are you just keeping it on the books and not actually collecting the rebate?
So by doing the sample, if the unsampled group proves to be the driving force behind the cost, how then will you be able to assess what we need?
Well, a sample that is done scientifically and appropriately is representative of the entire universe.
Oh, okay. Thank you.
Yes. And on the individual basis, I know you raised a concern about that. Again, this would not be the redetermination on each individual. Has to be done on a continuous basis every month, because people come on Medicaid every month, they stay for a year, so each calendar month of the year you're dealing with a different group of